Amanda, you have to activate the sharing. Cool.
Michael.
Yeah.
We have a few people that have already joined, but I just wanted to say, can you remind people if they want to speak, they'll have to raise their hand and then I can allow them during the question and answer time?
Sure.
Okay, thanks.
Hi, Paul. If you're gonna want to speak, Amanda has to unmute you. So you just put it in the chat. Hello. Hey, Paul, I'm gonna attempt to share screen. I want to just verify if it works. So you can see the screen in a second. Paul, if you can put in the chat, if you can see the screen that says we are CMH. Thank you. Okay. Looks like we got 3 people in. We'll just give it a couple minutes.
When I checked yesterday, we had about 11 people registered, so hopefully more people will join soon.
Yes, okay. You know, when we had to cancel the one 2 weeks ago, it throws everybody off, you know. I'm gonna quickly just run to the restroom and come right back. No, I'm doing my thing, my work part, my training a little bit. You know? Okay, back. Okay, I see we added Vonnie. So everybody that's on the line already knows the information I'm going to talk about. So we'll do an abbreviated version of this. Um, if you want to talk, raise your hand so Amanda can um, unmute you. So a lot of the CMH staff that normally participates in these, they're outside because we're having a retirement party for Michelle Vanderskel, who is retiring, and there's puppies out there. It's like a puppy party. Um, so, you know, I'm gonna wait probably 5 more minutes and then get started. But if it's just the 5 of us, then I'm gonna kind of do an abbreviated version of this. Um, and it is being recorded, so we'll get it out there. So we'll just wait for another minute or so. Okay. 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 Paul, if you could raise your hand so Amanda can test unmuting you and then talk so I can make sure it's working so I can hear people. There he is.
Can you hear me?
I can now, thank you. Now I can see you too.
Yeah,
Or
okay.
yeah. Okay, well, we'll get started. What is it? 12:07. Okay. Everybody I can take it can hear me. If you can't, just put in the chat and I can help you fix that. So what I wanted to do is provide or remind basically our community of some of the historical roots, very briefly, of the CMH system, what makes us distinctive, and what the community will lose if indeed the state moves on with their plan to, in my opinion, privatize the community mental health system. Um, those on the call, if you don't know, or for the recording, the Michigan Department of Health and Human Services released their intent to restructure how the Medicaid CMH benefit is managed and deal with, and do changes of how community mental health organizations or departments or agencies interact with the level of our system, which are called PHPs or regional entities, manages the benefit. And I want to take this opportunity to do a basic, very general, not a detailed, education on how community mental health is really like, I believe, like the fire department or the police department. It's a pivotal community service that goes way beyond healthcare. And I think people sometimes forget, sometimes in this kind of environment we've been in the last, say, 10, 15 years, you hear even community mental health have been changing their names from community mental health to Health West or On Point. And there's some good reasons to do that, to change the name. But over time, people may not be aware that these organizations are actually community mental health organizations as outlined. Now, sometimes that's the point in changing the name to help with stigma. Sometimes when you change the name, people will feel more comfortable going, but to get community mental health services. But I do think that we lose something when we don't keep this connection, and I want to kind of go through it. So at any time during this presentation, you have a question, or you want to make a comment in support, just raise your hand. Amanda will see it, and then she'll unmute you, and I'll stop talking and listen. So we can make this, since there's only a couple of us, more of a dialogue. And for those that I know that are on the call that know the system, it's just a reminder how big the stakes are if the community mental health system gets privatized. So I'm going to share my screen. Any questions so far on what we're doing? Okay. Okay, so you should see a screen that just says, "We are CMH, understanding the unique CMH tradition of care." Okay. So what I'm going to do is do a brief history of the Michigan public mental health system, and I'm pretty brief. The current structure of our system, just to remind folks, and those that work in it kind of know this already. And then really the distinctives of the characteristics of our system of care or traditional care. And then finally, what would be lost if the state privatizes the public mental health system? And you're going to hear me say continuously throughout this presentation, or dialogue, I should call it, tradition of care. Community mental health and the services that we provide to the community is a distinct tradition of care with distinct philosophical and theoretical principles, which I'll cover later in this discussion, that are not replicated anywhere else in the state for any provider that's providing behavioral health services to the mentally ill, to the severely emotionally disturbed, to IDD, autism, substance use populations. I'm going to argue that we have a very unique tradition of care that cannot be integrated with other models of care, especially the medical model. And so because of that, kind of my introductory remarks like that, it should help people realize, you realize that we're beyond healthcare. We're beyond a mental health provider or a housing provider or doing habilitative services for folks. We are a distinct tradition of care that is not replicated anywhere else, period. And I'm going to tell you why right now. So hopefully you can see the small print. If not, I'm going to go through it. You know, there have been many distinct steps in forming community mental health across America. In Michigan, there's been a timeline, and I've only highlighted a couple of these, well, more than a couple, knowing that there are millions of steps in between these broad strokes. But I want everybody to understand that, you know, it really, you can even go all the way back until the 1800s, believe it or not. The notion of treating people outside of psychiatric institutions or even having them is a relatively new phenomena of taking people out of institutions and putting them in the community. Like relatively new as 1959. Like there are still people, believe it or not, that are alive today that never knew this system growing up. It wasn't there. It started in 1959, really, in Michigan. There was a Society for Mental Health Study, a group of people that came together, and they were kind of in response to what was happening nationwide. And then you'll see in the 60s with JFK and others, folks making the Community Mental Health Services Act. But people in the 40s and primarily in the late 50s said, okay, we need to really start addressing mental health differently in the way that we view that. A lot of that had to do with the advent of medications that were very effective, but a desire to get people out of institutions. But in 1963 is really when our movement, our tradition of care, really truly began. The Community Mental Health Services Act, or Act 54 of the Public Act called then, it was then that as a national standard, that we were going to move to community mental health services and community mental health organizations in a coordinated way to deinstitutionalize people with mental illness. Now, you notice I'm not saying IDD or autism or developmental disabled yet. They came along later, but originally it was just focusing on mental health and mental illness and severe mental illness. So this led to, in 1974 and 1975, the Michigan Mental Health Code became effective. And that is the birth, my friend, of community mental health. We were created with the Michigan Mental Health Code. We were around, but we were mandated to exist. And just like my shirt says, Community Mental Health of Ottawa County, that's when it all began. It didn't start in every county right away, but it started to spread in the 70s and the 80s. As counties were coming up in the 70s with this mandate for the mental health code. And so you don't find this in any other type of healthcare when you think about it. If you think of healthcare, you don't have like you have public health acts for sure, but the establishment of specific organizations to cover one subpopulation of the public, the mentally ill, and then eventually IDD and substance abuse. You don't see that. You see that in Michigan and across the country during this time that community mental health as a tradition of care and an organizational structure to do care was born. In the 80s, everything was cool in the 80s. There was the 80s report that helped inform needed revisions that's going to need for the mental health code. But what it really did is it gave community mental health organizations like ours, or departments, or county departments like ours, full management of public mental health. So, of course, this was done in partnership with the state, but we have always been, from the beginning, expected to have full management and integration and control of the public mental health system, community mental health, not anybody else, just us. Later, you'll hear that we have these regions that appear, these Medicaid PHPs, but that's just because the system moved primarily to Medicaid funding and we moved to a managed care model. But in 1995 and 1996, there were several mental health code revisions. And it allowed CMHs to no longer just be a county department, because they all started off that way, but you could be multi-counties. So several counties could get together and say, we want the department run by one organization for multiple counties. Paul, that's on the call, and myself, we worked for one for a long time. Clinton, Eaton, Ingham County, 3 counties coming together, managed by one CMH, but they're all still connected to the county in one way or another. This also allowed for the emergence of authorities, CMH authorities, and that's non-county departments or organizations within multiple counties. It was a freestanding kind of organization outside of county government. And that's how you got all these mental health authorities, which is the primary way, which I'll talk about in a moment, where CMHs are structured now. They're not county departments like Ottawa still is. But Ottawa CMH, just for the public to understand, has its connections all the way back to 1960, 63, as a county department, as a part of county government, as intended back then for all CMHs. In fact, all CMHs were county departments. It's only been a relatively new phenomenon in our history since 96. I know that sounds a long time ago to some people, but not me, that CMHs could be anything but a county department. And I'm going to tell you why that's a distinctive in a moment. I'm going to get through 2 more of these, and then I'll see if there's any questions or comments on what I'm saying, or if people would like to add to it, because I know we have people on the phone, on the call, that know a lot more than I do about this. So 1995, 96, the Mental Health Code gets significant revisions. One of the most important revisions is it mandated consumer and family participation on CMH boards. We are the only system that mandates consumer and family participation and governance of the system. Nobody else is mandated. They may do it, but we're mandated to have people that are receiving services and or family members and county commissioners to manage our organization. Why? Because there's a connection all the way through time to county government, community integration and participation throughout our history. It's a staple. So before I get into what I call the period of managed care, is there any questions or comments on what I've described so far in a brief timeline of some kind of historical landmarks for community mental health? And again, you just have to raise your hand, and then Amanda can unmute you. Any comments that people want to make or questions? Okay. And Amanda, if you're seeing none, just if you could just, because I can't see the hands or anything, you can just say there's none so I can move on.
Nobody's raising their hand right now.
Okay, great. All right, so the era of managed care started about in the 90s. Throughout the country in the 80s, managed care hit. It got to behavioral health in the late 80s and the 90s. And managed care, basically, the basic principle is to manage the entitlement benefit, and it's to really have safeguards on who's authorizing the service and who's providing the service. And we've always had a blended system for community mental health where we authorized and provided the service. as Medicaid and the waiver system that we have, Medicaid waiver system we had, came into fruition, what happened is the state had to go to a model where they have PHPs, which stands for prepaid inpatient health plans. We call them regional entities that manage the Medicaid budget and funds we get from the feds through the state with the CMHs. So in 2004, we, the CMHs, it's very important to understand that, we, the CMHs, were allowed to create these regional entities ourselves. Why? Because we've had the mandate all through time, since 1959, to be full managers of the system. So this seems confusing to some people, but the PHP system or regional entity system we have now is made up of CMHs that wrote the bylaws, that created the entity, that put board members on the regional entity. And there's some other ways board members get on it as well. But in essence, these PHPs or Medicaid managers we had, right, are in complete partnership and are only allowed to be organized right now in the mental health code by CMHs coming together. So the state said, you got to come together, you got to form these other entities, you got to have a layer of managed care management above the CMH level. Okay, and so we came up with 18 of them. There was no rhyme or reason on the number. It's just groups of CMHs coming together, and it didn't even have to be contiguous counties touching. You know, I was part of the original affiliation of 18 where we had Manistee, Benzie, and I was working in Lansing and Clinton, Eaton, Ingham County. And so that they don't touch each other or any of the other partners we had. So we formed these regions to keep the tradition of full management and care aligned with the new expectations of managed care. So that's why they were created. There's a lot of other reasons too, but that would be like a 3-day seminar. So what happens? We do 10 years of this. And then we say, you know what, there's too many. The state says there's too many. The federal government's like, there's too many of these managing things. They're not all aligned. They're not all do the same thing. And so there was a movement to reduce the number of these regions or PHPs down to a number. And we ended up settling on 10. And that's the current structure we have now. There are 10 regions with 46 CMHs within one of those regions. Either one of them, I'll show you that in a moment. But it's important to understand that while there's this managed care entity that works with the CMH, formed by the CMH above them, okay, the community mental health system or CMHs are still responsible to carry out all of the mandates in the mental health code, regardless of how the state structures it. So we cannot just simply be eliminated or privatized. We are the system. This is our history on the screen. The PHPs, these managed care entities, is a recent phenomena in time. Not the entire, it's not always been like this. And so it's important to understand that. And again, if you have questions or a statement, feel free to raise your hand, or if people know me, I'm just going to keep going. Okay. So for the public, of those that don't know, what are kind of some of the characteristics of this CMH regional entity management structure? And again, I'm spending time talking about the structure. I'll get into later the distinct tradition of care things that we do that make us different than everybody else. But the current structure is 46 CMHs within those 10 regional entities. And remember, the regional entities in the mental health code can only be formed by the CMHs coming together and forming that organization. And some people have said, oh, that's a conflict of interest, and that's why we have to separate CMHs from the PHPs, and we need to separate them. What people are forgetting, it's because of our existence and our relationship to the historical timeline and the mental health code, really, we still have the responsibility of managing the system, regardless if the state wants Medicaid managed with another layer above us. It's still us that's supposed to do it. So we have a direct partnership with the Michigan Department of Health and Human Services. The regional entities do on the Medicaid side, and we do on the general fund side. But our obligations in the mental health code doesn't change. There's a direct relationship between the current structure and the state, right? We share financial risk. We're all in this together. So within our regions and CMHs, we pool our resources together in that region. And if Ottawa overspends on Medicaid and other people in the region underspent, we move the money around. The PHPs do that for us. The regional entities do that for us. It's a shared risk pool. And if you sever that relationship locally with the local regions, like, ours is the Lakeshore Regional Entity. If you say, we don't need them anymore, we're going to have this big, huge blob one, and there's no connection to the CMH, then our ability to share resources for the benefit of people in our region goes away. So it's a shared financial risk model. We're all in this together within the region. CMHs with the region, sharing the resources, managing it the best we can, having oversight. And it's also a carve-out model, meaning our system in insurance lingo is a carve-out. So you have the Medicaid health plans, right? Most states, or a lot of states, the behavioral health is in that plan managed by the health plans. We have a carve out, meaning the behavioral health responsibilities for all the populations we serve, which I'll talk about in a moment, right? We have it and the health plans don't. Well, why is that, Dr. Bashirs? Because of the history. We were created and have never lost our responsibility to be the public mental health system for this state. And just because the state uses Medicaid with the partnership with the federal government to bring down more money, it doesn't mean that we can just be folded into a health plan and let the health plans manage it, because we are like the fire department. We're a carve out for a reason. We're carved out, meaning that we can manage this part of the Medicaid with our regional partners, right? Separate from the health plan managing physical health care stuff. But doc, don't you want to have an integration of that? Don't you want an integration of physical and behavioral health? And I'm going to tell you, unless we're talking about symptom reduction or reducing mental health symptoms, we don't. Because what you're going to see in about 2 slides is we do so much more than that as a community mental health system that you can't actually carve us back in or put us in with the health plans unless the health plans are going to be able to allow us to deliver our mandate that's mandated by law, mandated in the mental health code. We're not just healthcare providers. We're way more than that, which we'll talk about. So we're sharing responsibility in the current partnership, regional entities, CMHs. We're sharing and pooling resources to meet the mandates of the mental health code that started back in 1974. It goes all the way back to 1959. So hopefully I've spiked the football enough to understand that we're a distinct tradition of care that has its root in a community movement that made us the sole entity in the mental health code to provide the service, manage the service, provide access for people, and get people out of institutions. That's our role. It's way more than seeing a therapist or a psychiatrist in a medical model or getting some healthcare service provided to you at home or somewhere else. I wish we were just healthcare. This would be a lot easier, right? Okay, I'm about to move on. Any questions or comments based on what you heard so far?
So far, sorry, so far, no hands up.
Okay, how many people do we have in the meeting right now, just out of curiosity?
4 people.
Is it the same 4? Okay,
Yes.
all right. Well, I'm gonna keep going. All right. CMHers, wait, did I skip one? Hold on. No. We're more than healthcare. Community mental health has always been connected to county government. I'm making these points over and over again. We've always been part of it. Even now, even community mental health organizations or authorities that are not connected not as a county department are still connected to their counties. People need to know the county still appoint CMH board members, no matter if they're a county department or not. The county still has to come up with general fund, local county dollars to throw up to the state so that we can draw down some state general fund dollars for mental health. The counties are still connected. Ottawa, we're very connected because, like the original, we're like the original OGs. We're a county department, and that means there's a relationship between county government and the community in Ottawa that blends the two more intentionally. We're mandated via the mental health code to carry out the public mental health requirements outlined in the mental health code in partnership with the state. We are them. We are the extension of the Michigan Department of Health and Human Services via the mental health code. So privatizing CMH? What do you mean? We are part of the partnership outlined in the mental health code with the state. Now, can the state say we want other folks too, besides CMH, to manage Medicaid mental health benefits? Sure, I guess they could do that. But this little pesky thing called the mental health code, they're going to have to be very careful how you do that. CMHs provide comprehensive supports and services that exceed traditional behavioral health services. And I'm going to go over that more in a moment. I wish it was just behavioral health. Okay. So here's some more distinct characteristics of our tradition of care. One, it's consumer and family centered, both governance and planning. We are the only system in the state delivering any type of healthcare service that has consumer or self-directed options to how you get services, self-determination, things like that. And the whole person-centered planning movement began in the community mental health system nationwide. We started it. Our tradition of care said that all care has to be person-centered planning and this process of that and having the meetings and going over holistic goals for quality of life and all these things. We started it, not the private systems, not the private healthcare systems. Our unique tradition of care, CMH has started person-centered plan nationwide. We're the originals. Everybody else is trying to copy it, but they can't do it like us. We provide comprehensive services to distinct populations throughout the lifespan. Mentally ill, IDD, autism, SED, SUD, and I put what those mean up there. Now, through our history, things were added for us to manage, like substance abuse. That's a relatively new development, less than 15 years of us taking control of managing that. Why? Guess what? Folks with IDD or mental health issues or autism also have substance use disorders. So we were given the mandate to deal with the management that at these regional entity levels, and CMH has responsibilities. So we provide comprehensive service to distinct population groups of all ages. In the private sector, you might get a provider that specializes in A, or one group, or B, right? But we're controlling a whole continuum of services, which I'll talk about in a moment, for all ages, for distinct populations as part of a public system. So those are just three of some of the characteristics. I'm going to keep going. So like I said before, we go beyond the distinct characteristics of the stuff is also a full array of services that go way beyond traditional healthcare, like community living support, supportive employment, things of that like. Focuses on the whole person. We use evidence-based practices. The public CMH system is the only system in healthcare, when you're doing healthcare services, that we are mandated to use specific evidence-based practices. We don't have a choice. And I'm going to show you a handout in a moment that has those listed. But private behavioral health are not mandated to use any evidence-based practice. Someone can just hang a shingle up. Yeah, there's licensing, I guess. Start to talk to people and interact with them. without having to demonstrate that they're using the best practices to meet the needs of folks that need the services that we provide. We have to do that. Private entities don't. Community integration standards. We are mandated, it's in our name, community, to integrate people for full participation into the community. We have home and community-based standards, meaning some of the residential programs we have to have characteristics of like somebody's home. This is beyond institution. This is beyond traditional healthcare. We have to make sure our services are as integrated into the community as we can get. And we have a lot of we have contract providers with CMH that are part of us that help do that. And we do it. We have access to care standards. We get measured. How long does it take somebody to get into treatment once you assess them? Once you've assessed them, how long did it take for treatment to begin? Somebody goes into the hospital. Are you going to see them within 7 days of discharge? In private practice, one of my biggest frustrations was one of my clients would go in the hospital wouldn't even call me and say it's time for discharge. Or they just write a discharge plan that day and hand it to them. Sometimes you can't get people, and this is a frustration for the hospitals as well, into follow-up care in the private system for months. The next appointment's 2 months from now. We have to do it in 7 days. Why? Because we're the safety net. We are the safety net for crisis services. We are the fire department for behavioral health and crisis services. We work with jails. We work with law enforcement. We work with the courts. We assess people that need to go to the hospital. We have mobile crisis that goes out and helps people, regardless of fund insurance, to determine what's needed. We have access centers. We are the safety net for crisis services. We're not just a provider of behavioral health services like everybody else. You make us a provider, that goes away. I'm not going to sign up to be the safety net if I don't get to manage part of the system where people go and what they do. But Dr. Bashir's, if they change the system, they can just say the new entity that is going to manage the Medicaid will just contract that out to you. Well, guess what? In the state's new proposal, in the general description, underlined it in bold, it says this new PHP cannot delegate any managed care function. What we're talking about are managed care functions, determining level of care and where people go and how much of a service one gets through person-centered planning. We're part of that now. If this goes through, they can't delegate that stuff to us. Our whole provider network that works with CMH to make our mission would be managed by this new entity. We would be simply reduced to a service provider without the ability to meet our code mandated requirements. And some of the stuff, I'm just getting started, is what we do distinctively. We are the safety net. We focus on the full person. We do person-centered planning. We have governance that ensures consumer and family guidance for the whole operation. You think you got clients sitting at the Priority Health Board? As mandated, they may, but mandated? Nope. We're the only ones. Proud of it. Since 1960. So one of the things I'll send out to the participants is the board association. Hold on, I just want to make sure this switches. Okay. Okay, can you see this handout, or was I successful in doing that?
Yes, we can see it.
Okay, great. All four of you? Okay. So the Community Mental Health Board Association has a series of documents and white papers about the strength of the system. And you might not be able to read it well, so I'll make it a little bigger. That should make it better for you. And I just want to highlight a couple of things that are distinctives. One of them I mentioned is that we are mandated to use evidence-based practices. And this is just a partial list of what we have to do. And if Keith's still on the call, he knows the first one. We have assertive community treatment, which is a team-based model taking services to a person that has severe mental illness that may also, but not necessarily, but may also struggle with treatment compliance. We have assisted outpatient treatment. We have psychosocial rehabilitation, which I'll talk about in a moment. And you can see this list: DBT, family psychoed, motivational interviewing, person-centered planning, self-determination or self-directed care. These are all best and evidence-based practices that we are mandated and contractually obligated to provide as part of our agreement to meet our mandate in the mental health code to provide high-quality services. You may have people outside of the CMH system using these practices, but they're not mandated. They're self-selected by the clinician. So we are the only system that is in Michigan that's required to use evidence-based practices to ensure that the public mental health system is using the cutting-edge approaches. And these are very specific, annualized, described treatment. And it's only one aspect of what we do. We do far more than just evidence-based practices. But here's just a partial list. So our tradition of care, even though I'm going to argue goes beyond just like behavioral health treatment, when we are doing behavioral health treatment, guess what? We're using the best models. And things like assertive community treatment were developed within community mental health. We are the developer, our tradition of many of these. Family psychoeducation, that's helping people who have loved ones with schizophrenia and understanding that. Motivational interviewing is to help deal with folks with integrated kind of dual diagnosis treatment, substance use, mental health, those things. Person-centered planning, self-determination, peer services. It's like consumer-driven. These all started in the community mental health tradition. They did not start outside of us. We are the tradition that created these innovative approaches to behavioral health, public mental health services that go beyond just reducing someone's symptoms. We did it. Our tradition. Yep, we're bragging. So some of the other things is that, you hear a lot right now about, we have all these layers in the public mental health system. And that means for every dollar that tries to make it down to the client, that someone's taking a big chunk out of it all the way. So the time it gets to the client or CMH to deliver the service is like half of it's gone. We actually have one of the most efficient carve-out management models because we're working in partnership. And there's this way that's measured. It's called the medical loss ratio, the percentage of dollars spent on actual care. In our system, it's 94%. That means there's only 6% of the dollars, and it's a multi-billion-dollar system, so 6% is still a lot of money, but it's only 6% of the actual funding stays in that administrative managed care realm. 6. Health plans can be as high as 20 or 18%. 6. So you may think it's a big bite of the apple, so to speak, before the apple gets down to the person being served. It's not true. 94% of it goes to the services. And so you look at that medical loss ratio, and we have an average spend and administration cost of 6%. I challenge anybody to find another tradition of care that's at 6%, right? So it's important to understand that because that's some of the arguments, but my argument is our tradition of care. It's because we're sharing the management with these regions, because we are mandated by the mental health code and require access, that we're actually able to manage the system and get the money to the services that someone need in a better way than other systems or other traditions of care. We're at 94% of the dollars get to the services. If anybody has a question on that, let me know. So in this document, which I'll send out to you, there's an actual link to the white paper that this infographic is based on. And you can read the extensive research and analysis to make these claims. And so a tradition of excellence and innovation measuring the performance of the Michigan public mental health system. And we've had to do this because there's been this, if you just think of mental health and behavioral health, people are like, there's got to be a less expensive way. Well, that's if we absolutely were only doing behavioral health care, like just dealing with symptom reduction. And I'm going to show you what else we do. It makes that statement an impossibility. Okay. So, go ahead, Paul. Maybe, Paul, you can ask that because it popped up, but maybe it can be unmuted.
Well, it's not really a question, Michael. It's just
Oh.
an observation that with the proposed model that Ottawa would move from becoming one county within a region of 7 counties to one county within a region of 44 counties, while also losing any board representation at the new PHP level.
Right. That's right. So the tradition of care, and you'll see that near the end of this, gets destroyed. And I was going to go over that. It just crumbles. It will literally say the mental health code and what we've done since late 50s doesn't matter anymore. So why is that? Because we do other things, psychosocial rehabilitation. We understand in our tradition of care, it's relationship and community integration that's just as curative than reducing somebody's symptoms, or in habilitative terms, making sure they're not losing more than they already have, right? We've always had a balance of habilitative and rehabilitation services. We're not just about fixing something that has gone wrong in somebody to get them back to a better place, or we're about ensuring that people don't lose the loss of their current functioning or quality of life is a better way to say it, due to the special abilities or different abilities that they have. And that's definitely true when we're serving folks with intellectual and developmental disabilities. It's not about reducing something. It's about maintaining and increasing quality of life. We understand in our theoretical foundation to care about social determinants of care must be addressed. Housing, transportation, access to medical care. And our traditional care, through our supports coordination models and other things like behavioral health homes and things like that, address those issues. Social determinants of care, the things that prevent people from getting good care, access to care, transportation, in the like. In our tradition of care, unlike our behavioral health care folks only, we're all about supportive employment and housing models, right? And so we're looking at all of that. And then self-directed services or self-determination. These are all vital aspects of our system that go beyond symptom reduction, that go beyond diagnosis and treatment planning, that goes beyond the medical model. We're the safety net for crisis. We have a theoretical position of psychosocial rehabilitation. We have clubhouses where people come and they're learning, skill building, all of these things that go beyond symptom reduction. And what I'm afraid of is the state and their zeal to have managed care models advance even more are forgetting that most of the services that we provide are not in that same space. And I don't know how they're forgetting this, but it seems like they are. So, what would we lose if the CMHs are reduced to a service provider? I'm going to stop the share so we can talk to each other about it. What would we lose is the crisis safety net. what we would lose is a system that is governed by and for the people. Sounds like, oh, Michael, you're talking about the Constitution of the United States or something. Yes, I am. Our history since the late 50s has ensured that there's a public mental health system that fully manages access and coordination of care as a distinct separation from traditional health care for a reason. We're not traditional health care. We right now, the CMHs, through our arrangements with the regions, we manage our provider networks. Our providers, like things that we don't directly operate as CMH, one of our providers do, like say residential or therapy services. They're us. They're our vehicle of carrying out our mandate. So the providers in our provider network are not us. Even though we may directly operate some services, people should not be confused. We're not just a provider and then the region manages everything and sends it to us. We are responsible to carry out the mandates of the mental health code. And the providers is just a way for us to do that, just like the CMHs are a way that the PHP manages the Medicaid budget. And so I think what would also happen is the emergence of the medical model, symptom reduction, as the primary focus of care. So I had the opportunity of sitting in a meeting this morning with the family. And I'm with the family, and they want to have their loved one move out of a specialized residential home. And they have a home that they were able to purchase. And we had to sit there and figure out how we're going to develop a service array to meet their needs. You think the medical model does that? Nope. I have control over, because it's delegated to me in my role of the CMH director and CMH, of the funding and the supports to tailor make person-centered plans that could be self-directed or we could do it for individuals. No one's sitting in a private therapy office doing that. We are every day, our folks working with families. You know, our system is the only one that mandates family-centered planning. What do I mean by that? For adolescents and children that are receiving care from us, if their family's intact or their natural supports have to be part of the care. They have to be part of the treatment planning. They have to be part of the strategy. We have to support them in a family-centered way. In private practice, parents can drop off their kids to the therapy office, cross their fingers, and hope the healing's happening. There's no expectation of family treatment planning unless that clinician or provider makes it a priority. And I'm talking more than just every third session coming, oh, here's what we're doing. In our system, the family is the center. Nothing about that kid or adolescent without them. And if they don't have family, whatever the situation they're in, their natural supports, foster parents, guardians, whatever they are. We are a system that ensures that natural supports around people are intricately part of our planning. No one else does this. This is our tradition. This is what we do. Oh, you got a guardian and you're an IDD client, you're on guardianship. Your guardian is part of, in the center of the care planning process and decision-making process with us. No other healthcare space is doing that. Finally, I'm going to say that if indeed the state moves on with the plan to separate the PHPs, regional entities, from the CMHs, and the CMHs are somehow forced into just being a service provider, a lot of the services that we do to keep people out of psychiatric institutes are going to crumble because we won't be able to manage them in a management way at all. We can just pick a service we want to provide. And then another service provider will do another piece. We actually coordinate all that through the person-centered planning with one access to care, which the mental health code mandates. And I'm saying this it's going to sound very dramatic. The end of the community mental health movement will end, and the reemergence of psychiatric institutes will commence immediately. When this happens, We're already having hard times getting people into psychiatric beds. Imagine if all the supports around folks are not managed and coordinated by a CMH, and it's all individual contract providers to this new regional structure. What you're gonna get is no local coordination of care, no local coordination with law enforcement, with jail diversion, with court order folks. But Michael, you're mandated to do it. I know. But if we can't actually have any of the managed care functions that for Medicaid allowed us to do in partnership with this new entity, then we have no ability to do any of those things, to manage it, to manage the benefit. We would just have a contract to provide a service. We'd move to a fee for service model. We get paid when we do a service. Right now, we get paid the same amount per month, based on, a year's, figuring out how much we need. And we have to coordinate all of that within that budget. That goes away if CMH is turned into like fee for service. That just goes away. And it will be the end of the timeline that I showed you. The journey will stop. It will say 2026. The theoretical orientation and approach of community mental health ends. That's the day. Now, some of you that may watch this in the future because it's recorded and know me now that's on the line knew that I was actually in support at one time of reducing the number of these regional entities. Remember, it went from 18 to 10, and I was supporting it go to 1. And I had made some huge mistakes in my logic. But that proposal back then didn't sever the relationship between the CMH and the PHP. It still allowed for some of these functions to be delegated back to us so that we can keep our mandate in the mental health code. But I was wrong in supporting that because I forgot one truth that's right in the face. I should have seen it. Was so obvious I dismissed it. We are the regions. CMHs formed the regions. Why? Because we have to exist. Why? Because the mental health code. Why? Mental health code says we're responsible to ensure all this. And I forgot that basic connection between CMHs and the regions the way we have it now. You break that relationship, there's no local needs assessment that's going to happen. And that was an error that I made in judgment. I mean, I even testified in support of a one PHP, a one regional manager, because I didn't understand or didn't think through it severs the relationship, even though it tried not to, between the CMHs and who's managing the Medicaid. And it's going to be my argument that we're the only ones that are really supposed to do it. No matter how the state comes up with who manages the dollars and how I get it, I need to have the ability as a community mental health organization for Ottawa County to manage that benefit. And if I can't, then we shouldn't be a county department. We should then say, if we don't get to help manage it to fit our community needs, how is that connected to county anything? It turns from an entitlement to just a benefit plan someone can change. Ottawa County doesn't want to be in the health care provider realm only. It's community mental health. That's why we have our millage. We had to get a millage in our county from the taxpayers to do things that Medicaid won't, to keep community and community mental health. Because far too long, our Medicaid benefit in this state has been becoming more and more like a medical model. And this will be the last little way to do that. Sever the relationship from the CMH to who manages the Medicaid. You sever that relationship. It's the elimination of the CMH tradition of care because it cannot be integrated in the medical model because what we do transcends the medical model. It's more than the medical model. And my healthcare partners, if they watch this, they're going to say, boy, Brashears, you missed the mark on A, B, and C. But if they're really honest, traditional behavioral health care is medical model. It is symptom reduction, level of care based. Go here when your symptoms reduced. Go here when they get worse. Thanks, Paul, for coming. So at this point, I was going to open it up to any questions on what I was saying, and there's only a couple folks here. But if people have questions or want to make comments, this is the time to do that. If not, then that's pretty much what I wanted to say, is that we have a distinct CMH tradition that's in jeopardy. And I wanted to remind people kind of some of the history and why we have to be here. So anybody like to make any comments or ask any questions or have a dialogue? Now is the time. If not, I'll just end the recording.
No hands are raised right now.
Okay. Well, I want to thank everybody for attending, and I appreciate your time. Have a good day, everybody.